Okay, this is the ATI Mental Health Chapter 12, Trauma and Stressor-Related Disorders. Clients can develop a trauma or stressor-related disorder following exposure to an extreme stressor, perceived life-threatening events, or interpersonal violence. In the setting of repeated exposure to toxic stress from adverse childhood experiences, or ACEs, the brain undergoes changes that influence developing structures, altering health and behavior. It is important that nurses have an understanding of how to effectively assess and care for clients experiencing this type of disorder. Specific disorders: acute stress disorder, or ASD. Exposure to traumatic events causes anxiety, detachment, and other manifestations about the event for at least 3 days, but not for more than 1 month following the event. Post-traumatic stress disorder, or PTSD. Exposure to traumatic events causes anxiety, detachment, and other manifestations about the event for longer than 1 month following the event. Manifestations can last for years. Adjustment disorder. A stressor triggers a reaction causing changes in mood and/or dysfunction in performing usual activities. The stressor and effects are less severe than with ASD or PTSD. Dissociative disorders. Depersonalization, derealization disorder. This disorder is characterized by a temporary change in awareness displaying depersonalization, derealization, or both, often in response to stress. Depersonalization is the feeling that a person is observing one's own personality or body from a distance. Derealization is the feeling that outside events are unreal or part of a dream, or that objects appear larger or smaller than they should. Dissociative amnesia. Inability to recall personal information related to traumatic or stressful events. The amnesia can be of the events of a certain period of time or just certain details. Dissociative fugue. A type of dissociative amnesia in which the client travels to a new area and is unable to remember one's own identity and at least some of one's past. One can last weeks to months and usually follows a traumatic event. Dissociative identity disorder. Client displays more than one distinct personality with a stressful event precipitating the change from one personality to another. Pediatric disorders. Reactive attachment disorder, or RAD. The child does not turn to an attachment figure or parent for comfort or social interaction. Typically results in a child becoming withdrawn from adults or other caregivers due to unmet needs. Diagnosed before age 5, early childhood or infancy after 9 months of age. Disinhibited social engagement disorder, DSED, displays overly familiar behaviors toward strangers or those relatively unfamiliar to them, without regard for appropriate social boundaries. Results from inadequate caregiving during childhood. Diagnosed during childhood after 9 months of age. Health promotion and disease prevention. The nurse should monitor for and recognize child physical and sexual abuse, which can lead to ASD or PTSD, and report suspected cases to the proper authorities promptly to prevent severe trauma reactions from occurring. The nurse should recognize occupations that have a high incidence of PTSD, military or first responders. Clients should receive support and treatment before severe trauma reactions occur. PTSD prevention. Health promotion measures and prevent PTSD during and after traumatic incident, a mass casualty incident. During the incident, be aware of need for breaks, rest, adequate water, and nutrition. Provide emotional support for those involved in the incident. Encourage staff to support each other. Debrief with others following the incident. Encourage expression of feelings by all involved. Use offered counseling resources. Assessment. Risk factors. Adverse childhood experiences, ACEs, can result in psychological and behavioral manifestations in children, further creating stigma and creating a barrier that keeps children from accessing safe, stable, and supportive relationships. Those with greatest risk for developing trauma-related disorders are women who have experienced 4 or more ACEs or have a history of interpersonal violence. ACEs have become a significant risk factor for the development of trauma-related disorders. ASD, PTSD, and adjustment disorder. Exposure to a traumatic event or experience, motor vehicle crash, sexual assault, or physical abuse. For adjustment disorder, the event or experience can be less severe, like a breakup or relationship or loss of employment. Exposure to trauma experienced during a natural disaster, like a fire or storm, or a man-made experience, like terrorism. Exposure to repeated re-exposure to trauma in an occupational setting, experienced by medical personnel or law enforcement officers, can precipitate a trauma and less stressful related disorder. Living through a traumatic event experienced by a family member or close friend, an airplane crash or homicide. PTSD is a risk factor for other disorders, including dissociative disorders, anxiety, depression, and substance use disorders. ASD and PTSD. Severity of the trauma, duration of the experience, the amount of personal threat associated with the trauma, and whether it occurs far from home or in familiar surroundings. Individual vulnerabilities, past coping mechanisms, personality, and pre-existing mental disorders. Insufficient treatment following the trauma. Client social supports, societal attitudes about the situation, and cultural influences. Adjustment disorder. Pattern of lifelong difficulty accepting change, learned pattern or difficulty with social skills or coping strategies, which, when a stressor occurs, can trigger a stress response out of proportion to the stressor. Dissociative disorders, traumatic life event, childhood abuse or trauma. Expected findings, ASD and PTSD. Intrusive findings, presence of memories, flashbacks, dreams about the traumatic event. Memories of the event recur involuntarily and are distressing to the client. Flashbacks. Dissociative reactions where the client feels the traumatic event is recurring in the present, such as military veteran feeling that they are reliving a combat situation after hearing a harmless loud noise. Nighttime dreams related to the traumatic event. Avoidance of people, places, events, or situations that bring back reminders of the traumatic event. Trying to avoid thinking of the event. Mood and cognitive alterations. Anxiety or depressive disorders. Anger, irritability, frequently present. Decreased interest in current activities. Guilt, negative self-beliefs, and cognitive distortions, such as, I am responsible for everything bad that happens. Detachment from others, including friends and family members. Inability to experience positive emotional experiences, such as love and tenderness. Detachment from others, including friends and family members. Inability to experience positive emotional experiences, such as dissociative manifestations, amnesia, derealization, and depersonalization. Behavioral manifestations, aggression, irritability, and angry responses towards others, hypervigilance with heightened startle responses, inability to focus and concentrate on work or other activities, sleep disturbances such as insomnia, destructive behaviors such as suicidal thoughts or thoughts of harming others. Adjustment disorder, depression, anxiety, changes in behavior, arguing with others, or driving erratically. Dissociative disorders, depersonalization and derealization disorder, reports of feeling detached from one's own body or feeling that one's personal environment is unreal. Dissociative amnesia, lack of memory that can range from name or date of birth to the client's entire lifetime. Dissociative identity disorder, client displays two or more separate personalities. Each personality can be very distinct and different from the other. Diagnostic procedures, ASD and PTSD and adjustment disorder. Screening tools, the primary care PTSD screen and the PTSD checklist. Screening test for anxiety and depression. Ask about suicidal ideation and mental status examination. Dissociative disorders, physical assessment, electroencephalogram, and X-ray studies to show out physical trauma, traumatic brain injury, epilepsy, screening to rule out substance use, mental status examination and nursing history. Nursing actions. Assess recent and remote memory for gaps or contraindications. Check for family and occupational difficulties. Ask about occurrence or stressful events. Assess for depression, mood shifts, and anxiety. Use screening tools, the Dissociative Disorders Interview Schedule, Cambridge Depersonalization Scale, Somatoform Disassociation Questionnaire, and the Dissociative Experience Scale. Patient-centered care, nursing care. Trauma-informed care involves care management that regards the impact of trauma for the client and addresses emotional, psychological, and physiological needs. Universal trauma precautions. Acknowledge and assume everyone has experienced trauma. Consider the tone of voice, eye contact, and body language in all communications. Respect culture, gender, race, ethnicity, and sexual orientation. Support client choices when possible. Minimize noise levels. Practice self-care and reach out to others when needed. ASD, PTSD, and adjustment disorder. Establish a therapeutic relationship and encourage the client to share feelings. Provide a safe, non-threatening routine environment. Assess clients for suicidal ideation and take precautions as needed. Use multiple strategies to decrease anxiety: music therapy, guided imagery, massage, relaxation therapy, and breathing techniques. If the client is a child, involve caregivers in treatment if possible and use play, art, and other age-appropriate strategies to decrease stress. Dissociative disorders. During dissociative periods, help the client make decisions to lower stress. When the client shows readiness, encourage independence and decision-making. Use grounding techniques, having the client clap hands or touch an object. Avoid giving the client too much information about past events to prevent increased stress. Client education. Practice strategies to reduce anxiety. Verbalize negative feelings and progress at own pace. Therapeutic procedures. Cognitive behavioral therapy, or cognitive restructuring. The client is helped to change distorted appraisal of events and negative thoughts. Prolonged exposure therapy combines the use of relaxation techniques with exposure to the traumatic situation. The exposure can either be imagined through the use of repeated discussion of the traumatic event or practiced in real-world situations, in vivo, in which the client is exposed to the traumatic situation within safe limits. The repeated exposure eventually results in a decreased anxiety response. Psychodynamic psychotherapy, getting in touch with conscious and unconscious thought processes. Eye movement desensitization and reprocessing, EMDR, a therapy for both children and adults that uses rapid eye movements during desensitization techniques in a multi-phase process by a trained therapist. Contraindicated for clients who have active suicide ideation, psychosis, severe dissociative disorders, detached retina or glaucoma, or unstable substance use disorder. After developing a treatment plan, teach relaxation techniques to enhance client coping during next stages of EMDR. Group or family therapy can include support groups or formal therapy. Crisis intervention immediately following a traumatic incident. Somatic therapy for dissociative disorders. Psychotherapy works over time to increase awareness of the present and decrease dissociation episodes. Hypnotherapy can be used for dissociative disorders. Biofeedback and neurofeedback helps the client learn how to increase awareness and gain control of reactions to a trigger. Interprofessional care. Refer clients to social worker case managers for coordination of community care. Collaborate with psychotherapists to ensure coordination of care. Client education. Utilize relaxation techniques and other anxiety-reducing strategies. Monitor for causes and manifestations of the disorder. Avoid caffeine and alcohol. Perform grounding techniques for dissociative disorders. Observe and experience physical objects, touch a piece of ice, take a shower, or situations, and to keep a written journal to identify emotions associated with experience. Major medications to treat trauma and stressor-related disorders. Antidepressants, selective serotonin reuptake inhibitors, paroxetine, sertraline, fluoxetine, escitalopram, and fluvoxamine. Serotonin norepinephrine reuptake inhibitor, venlafaxine, tricyclic antidepressants, amitriptyline and imipramine, monoamine oxidase inhibitor, phenelzine, non-adrenergic and specific serotonic antidepressants, mirtazapine, which is NASSA, beta blockers, propranolol, decreases elevated vital signs and manifestations of anxiety, panic, hypervigilance, and insomnia. Peripherally acting anti-adrenergics. Prazosin can decrease manifestations of hypervigilance and insomnia. Centrally acting adrenergics. Clonidine. Adjustment disorder and dissociative disorders. Medications might not be prescribed for adjustment disorder or the dissociative disorders unless specific findings of depression or anxiety require treatment. A nurse is involved in a serious and prolonged mass casualty incident in the emergency department. Which of the following strategies should the nurse use to help prevent developing a trauma-related disorder? Take breaks during the incident for food and water. Debrief with others following the incident. Take advantage of offered counseling. A nurse working on an acute mental health unit is caring for a client who has post-traumatic stress disorder, or PTSD. Which of the following findings should the nurse expect? Difficulty concentrating on tasks, negative self-image, and reoccurring nightmares. A nurse is collecting an admission history for a client who has acute stress disorder, or ASD. Which of the following client behaviors should the nurse expect? The client expresses a sense of unreality about the traumatic incident. A nurse is caring for a client who has derealization disorder. Which of the following findings should the nurse identify as an indication of derealization? The client states that the furniture in the room seems to be small and far away. A nurse in an acute mental health facility is planning care for a client who has dissociative fugue. Which of the following interventions should the nurse add to the plan of care? Work with the client on grounding techniques.